Series of MCNS. Today's topic is complications in spine surgery, prevention and management. So for this webinar, we have the moderators, Dr. Abhay Kumar and Dr. Chandan Mohanty. Both are from Mumbai. And we have the eminent panelists, Dr. Pragnesh Bhatt from UK, Dr. Sushil Patkar sir from Pune, Dr. Varnan Miller from Mumbai. And we have the three speakers, Dr. Dattaprasanna Katikar from Solapur. He will be talking about complications in cervical spine surgery. The next speaker is Dr. Sachin Borkar from Delhi. He will be talking on complications in thoracic spine surgery. And third speaker, Dr. Sudhir Dubey from Delhi. He will be talking on complication in MIS TLIF. There will be discussion after all the speakers have presented, and panelists will have throw some lights and about the complications and management. So for this interesting topic, I would like to request Dr. Abhay Kumar to proceed further. So I would like to hand over to Dr. Abhay Kumar. Please, sir.
Yeah. Thank you, sir. Thank you. Firstly, let me thank all the speakers and the panelists for accepting my invitation and being here today. Let us start because it's already 8:34, sorry. So let's start with Dr. Katika, sir, speaking on complications in cervical spine surgery, prevention and management. Sir, please go ahead.
Yeah, I'll just share my screen.
Yeah.
Good evening, honorable panelists.
We can hear you, sir.
Yes.
You want to put it on a full screen, sir?
This is already full screen?
No, it's not in the power editing mode. It put it on a slide mode, sir. It's
Slide
in the
mode.
Yeah.
I think I may not be able to get it here.
Just go into slideshow.
Yeah.
Slideshow.
Just go it on the slideshow, sir. Up.
Up. On top there is slideshow next to animation.
On the first row, sir. On the first row, can you see that home, insert, design, animation, slideshow? Can you see that?
It's not there on this laptop. So.
Okay. So you want to go ahead with the.
Yeah, I think instead of. Oh, that's
you can't.
Yeah, I think I cannot.
Okay. Okay, so please go ahead then. Yeah.
Just a moment. I'll give.
Yeah.
Is this now the slideshow? This is what my slideshow shows.
No, it's not on the slideshow yet, sir.
This is what it shows me as a slideshow. So I think let's start here because. But there is also a screen.
No, we can see the screen, but it's not on a slideshow.
Yes.
But if you're unable to do that, then go ahead, sir. We can go start.
Yes, sure. But now this is not going up and down. Okay. Good evening, the honorable panelists, moderators, teachers, seniors, and my friends. I am here to share my experience on the complication in spine surgery, prevention and management, especially about the cervical spine surgery. There are two ways to learn. I am offering you the second option, which is absolutely free. The complications of anterior cervical spine surgery, the overall morbidity is supposed to be low. It is 1/3 compared to the posterior approaches. And people got confidence to such an extent that the safety and efficacy was being evaluated to make it an outpatient procedure. Still, when we enumerate the complications, the number of complications as we see enumerated here, the total, if you take, it goes beyond about 6 to 8%. So whenever you reach a number of 200 in your career of operating spines, you are going to encounter one of them sooner or
Sir,
later.
your slide is not moving, sir. Think, are you
Okay.
going, you are still on the first slide.
Oh, I'm so sorry. I'll stop here and again come.
Yes, sir.
Now it is on the full screen mode.
Yeah, so yeah, we can, the slide is, the slide which
Showing
you're
this.
seeing now is the
Oh.
complication in anterior cervical spine surgery. Yeah,
Sure.
can go ahead, sir.
I'll just check if I can change, but no, I am not able to change.
It's moving now.
Yeah. So the overall morbidity was so low, 1/3 as compared to the posterior approach, that people started thinking about safety and efficacy of it being evaluated to make it an outpatient procedure. But still, the number of complications enumerated, if you take all of them together, it's not a very less number. They approach more than 5%. So when one does operations more than 200, they are going to encounter one or the other. The adjacent segment disease, the experience and seniority will teach us. I remember Dr. Patkar sir 25 years ago asking us that how many adjacent level disease you have seen. So all of us would not say, no, hardly anything, and it's a myth or not. But now we understand that you have to put in and years of experience so that the adjacent disease segment patients of yours and others, they start coming to you and you understand that it is still there. The dysphagia is supposed to be usually mild, temporary, but is not uncommon. It usually subsides in 2 to 3 days or even at the most by a week. The most severe form of this esophageal injury. The immediate has become rare because of availability of the operating microscope and the new instruments, but it still happens. It may rarely happen. I am sharing you with a case which has happened 4 years after the operation. So the first slide that shows that there is elevation of the airway from the anterior cervical plate and the lower screw has slightly moved. So I was and the patient came to me in difficulty in swallowing and pain on swallowing. So I thought the screw is just little moving and it may not be the cause. So we did an MRI. The MRI showed us collection in front of the cervical spine without any edema on the bone. So we went to an endoscopist. The endoscopist did an endoscopy and he showed us that there is a small injury in the piriform fossa from which bleeding is seen. So he felt that if he has eaten any fish or any hard bone, it might injure. The patient denied to say so. But then he felt that it is most probably because of this injury. So we went on giving him antibiotics. But after that, and we did also a contrast CT scan with oral contrast. The oral contrast did not leak into the site. So we felt now it is safe, and with antibiotics, it will slowly subside. 10 days after the oral antibiotics, the patient came back with this picture. The lesion has increased in size. The lower screw has, that is actually the locking screw. We put the locking screw over the two heads to lock the other two screws. That has come off. So we took him to the OT. On OT, we see that screw is not seen only, but in the AP X-ray, we are able to see the screw. And when we entered inside, there was a huge phlegmon with 15 to 20 ml of pus. And after we draining, there was a thick encapsulated abscess. We could excise the whole abscess wall, and we were able to remove the screws and plates, and the patient is doing okay after that. Postoperative hematoma is not very common in ACDF, but we do encounter occasionally when we are doing a corpectomy. Here, I feel the main causes of oozing are mainly either the small vessels which are arising from the OPLL or the ossified part of the OPLL, which we may not be able to coagulate on occasions, but more common is the oozing from the cut edges of the bone. While seeing it at the end of the surgery, we see there is hardly any amount of oozing, but a small trickle may go on accumulating, and after we put in a cage or an implant, this becomes invisible, and afterwards it may slowly accumulate over a period of time to have a significant size to compress the thecal sac and the cord. So here the trick is being very diligent and early recognition and urgently exploration and evacuation will give a good outcome. I always put a 8-number drain, but it hardly drains anything. But I felt whenever there is a collection of this, the 8-number drain will become inefficient. So I have switched over to 12-number drain now. So the CSF leak. So I show this case because this was a case in which I operated an endogenous cyst placed anterior to the cord, and I could excise it totally with no chances of recurrence. But after I shared this case, one of my teachers asked me, Kartika, tell me how is the patient? So I said, sir, the patient has gone on day 4. Second teacher asked me, why are you choosing such a morbid procedure for a simple case like endogenous cyst? So, sir, I told him actually because now these cages and implants are available and we are able to do it very smoothly. We do not think it is a very morbid procedure. Because after doing the corpectomy, the whole dura was available anteriorly. I had enough space to take the cyst sutures to excise the endogenous cyst. At the upper level and lower level of the endogenous cyst, there was a small vessel which was feeding it. That also I could coagulate, and I had enough time to, and I had enough space for my instruments to close the dura. Whenever CSF leak occurs, either in ACDF or after corpectomy, my experience is that if we have done an adequate spinal decompression, these will spontaneously heal. On day 1, day 2, on occasions, I have seen CSF coming out through the drain. But when the decompression is adequate, when the normal passages are open, all the abnormal passages have to close. And in cervical spine, I never had to go back, re-explore it, and close the leak. There is inadequate decompression is another important thing we have to take care of. Now, this is a case in which there was a huge OPLL. Surgeon tried to go from anteriorly to do the corpectomy. Unfortunately, the patient also had anterior ossification of anterior longitudinal ligament. So by the time he removed the ligament, by the time he removed half the body, he thought that he has already reached the cord, and he put a cage and he put the plate. But the patient has half the body behind the cage, and actually the patient did not improve because there was no decompression of the cord. So we went from behind, we did a laminectomy, and he improved. It is very important for us to know that adequate decompression is we should see the dura from the upper level to the lower level and to the lateral side until we are able to reach the origin of the roots. I have made myself a habit that whenever I have completed a corpectomy, I put a blunt hook under the edge of upper and lower vertebra and move from right to left or left to right to know that there is no compression by the osteophyte or anything else. The another thing is increased neurodeficit. I would like to share this case because I felt my threshold for corpectomy was very less. So my teachers, they told me, why don't you try ACDF and do it? So this was a case in which I tried to reach the dura, but there were huge osteophytes which were very strong. And while trying to remove the osteophyte, I had to drill almost the C5 to half of it. But in spite of that, I could not reach there. But still, I was struggling. And when I was removing the last piece of the OPLL attached to the dura got torn. And the bulge you are able to see there is actually the arachnoid prolapsing inside the small wound. Now, in such a narrow corridor, it is very disheartening to see the arachnoid bulging and the cord and the roots around being seen through that small hole. So I had to go ahead and do the corpectomy 1 level above. Then I was able to see the virgin dura, and from there I could come down and close it. So I have made myself a protocol that whenever the compression is more than 50%, I go for a corpectomy. Like in this case. So here we are able to go to a level where the compression at the disc level is comparatively less. We can reach the dura, we can remove the osteophytes, we can do the corpectomy, and then we have enough space to see that how we should approach that. And as this is seen on the CT scan, the OPLL of the upper vertebra is reaching so high that by doing just ACDF, I don't think I would have been able to remove the whole osteophyte there. So like in this case, there are huge osteophytes seen on the posterior side of the vertebra, and in the post-operative picture, all the osteophytes have been removed. I have made a protocol that I'll take a pre-op picture and a post-op picture, and unless the whole osteophytes are removed on X-ray, so I will not stop myself. Then there are giant disc herniations which are migrating below and above the lower or upper vertebra. So here I feel corpectomy makes it a cakewalk, because when I try to remove through the ACDF, whenever I have removed the part lying in front of me, I feel I have removed the entire disc. But there might be some part of the disc lying below the upper body or the lower body, which I may miss, and postoperatively the patients have issues. So whenever I have this lesion extending more than half the body of the lower or upper vertebra, I always go for corpectomy. So I feel I might be slightly overdoing it in view of few people, but this makes my life very comfortable, and the patients they show good recovery. And as we said, the morbidity with the corpectomy has become much less over the years. So there are issues of donor site and allograft issues. I remember patients coming to me after ACDF, there is no pain in the neck, but pain in the iliac crest, pain in the thigh, pain in the walking. So in those days, I felt that we are not explaining the patient that there will be operation in the neck as well as in the hip. So they accept the pain in the neck, but they feel why there is pain on the iliac crest. So you might have read the paper. Dr. Parthiban had introduced an idea to take the bone graft from the adjacent bones and put it to fill up the cage. So from that, I took an inspiration, and I felt the, the anterior and posterior osteophytes are a great bone for fusion. I do not use the drill now because the bone dust will be difficult to get together. It may spill off. I use the scoops of bone harvested by the sharp curate. Here, I do not insert the scoop between the dura and the osteophyte, but I go laterally, tangentially, and here I am able to remove adequate amount of the bone graft, which you can see in the center picture, which can fully jam pack the case. The image on the left side shows there is that is empty cage. Image on the right side shows that it is packed with the bones. So the vessels injury, the vertebral artery injury is very uncommon, but when we do an excessive drilling and we ignore the lateral boundary of our lesion, it may happen. And in these occasions, we may have to call our cardiovascular friends to help for it. Carotid artery injury nowadays has become very less. On few occasions, there are aberrant vessels which are coming from the carotid artery and they are crossing our axis. So while cutting them, it may happen that they get retracted and there is a difficult time coagulating them as they are very near to the parent injury. The internal jugular vein injury, though uncommon, I remember because I was called once to help. I was called that he has injured the jugular vein. And by the time I reached there, it was half an hour. And I saw they had packed it, everything, and everything was oozing as they were opening. And I was not very confident that I could repair the jugular vein effectively there. So being the patient was young, we decided to ligate the jugular vein. And fortunately for us, the patient did not have any problem. Similarly, the recurrent laryngeal nerve palsy and the Horner syndrome. Horner syndrome, the percentage has been given as 0.1%. It happens whenever you do much amount of dissection and coagulation on the lateral side under the muscles. So here I would like to say that whenever anyone under the longus colli muscle. So here I would like to state that whenever we start doing the case, I have seen people who assist me and who started learning that, or even when I started learning, why should I talk about others when I started learning? Because the incision is on the right to the midline, we feel it is anterolateral approach. We have to keep it in our mind. It is not anterolateral, it is an anterior approach. So when you think it is an anterolateral approach, one tends to go slightly laterally. And by the time you do the muscle dissection and reach, you are bang on the body of longus colli a bit laterally than where you should be. So here, all these, the nerves and the arteries and vessels, they come into your way. So the trick I felt was that I just go 1 centimeter near the midline. And when I go, I am bang on the body of the vertebra. Not doing a CT scan may present surprises. Dr. Patkar sir has always been telling us to do a CT scan for the spine cases I would admit that I was not doing it maybe for the economic reasons for the patients, but I have learned it a hard way. Whenever there is a compression like this, it is horrendous to look at, and how are you going to remove the spike which is going inside the cord, and how effectively you will be able to decompress. But you do the scan and everything stands in front of you. The anterior part, the spike going in which direction, in which angle. So then you are very comfortable to go inside and remove the proper part and come out. Loss of cervical lordosis, whether to call it a complication or not, as we talk about the global spinal balance, the lordosis is important to be maintained. I feel because the patients we operate for the cervical spine, they come with severe pain, weakness, inability to stand, ataxia. They are happy that they are able to regain those things. But then over a period of time, they are going to complain about the pain in the neck and other complications and other symptoms because of loss of cervical lordosis. When I started putting the cages, I was very happy. But when I reviewed my cases, I felt the first and second images, they show that there is definite decrease of corpse angle. The fourth and fifth images show that the vertical line has gone much beyond than what is acceptable. The central image shows whenever you put in the cage, there is always a gap between the interface of the cage and the vertebral end plate. In order to reduce this space, we will decrease the extension and would end up with a spine with a lesser amount of lordosis. So to prevent this, I have devised an expandable cage which can correct and maintain the cervical curvature. I had applied for the patent and I have got it. And now we are in the process of manufacturing. Here, I propose that you can adjust the angle of the upper and lower planes of the cage to whatever angle you need, to whatever calculated angle you want for the accurate lordosis of this patient.
Sir, yeah, 1 more minute, sir.
Sure. Sure, sir.
Yeah.
I'll go ahead.
Yeah, go ahead, sir. Just 1 more minute. Yeah, go ahead, sir, please.
Sure, sir. Yeah, I'm about to finish. Yeah.
Yeah.
The complications of spine surgery from the posterior approach, they're almost similar to what we get from the anterior approach. So in explanation, I don't have to do anything more than this. There is more incidence, but I think it is a fallacy because the population is older. There is multiple level disease, usually more than 3 levels, which anteriorly we are not able to do. We are going from behind. We have more comorbidities and higher severity of the spinal pathology. Patients being older and frail have chances of adverse events and surgical site infection more. Here, I think the main thing we have to think about is a prehabilitation of the patient. We have to build up the patient wherever we can and have a better patient, a more fit patient to undergo this. The worrisome problem is the C5 palsy. The causes were given as iatrogenic injury, spinal cord ischemia, reperfusion injury, tethering of the nerve because of shifting spinal cord. So here they have proposed that you can do a foraminectomy or you can give a selective block laminectomy in order to decrease the amount of tethering of the nerve, from shifting spinal cord and opening up the intervertebral stenosis. They have presented as increased laminectomy width also, but it has not been proved. Thank you.
Katika sir, thank you for an excellent presentation. So request you to stay
Sure,
until
sir.
the end, sir,
Sure,
to answer the questions. Yeah. So if anyone has any question, they can put it on a chat box. The speakers can simultaneously answer the questions as well in the chat box. Chandan, over to you.
Thank you. Superb presentation, Katikar sir. Now it's my pleasure to introduce my very good friend and professor of neurosurgery from AIMS New Delhi, Dr. Sachin Borkar. He'll be talking about complication avoidance in thoracic spine surgery. His talks are always crisp and to the point, and I usually learn a lot from his presentation. So looking forward to it. Over to you, Sachin.
Yeah, thank you so much, MCNS, for this kind invitee. I hope my slides are visible and I am audible.
Yes, yes.
Yeah. Okay. Thank you so much. I'll try to be crisp, but the topic is quite vast. So let me try to do justice to what has been asked of me. So I have no disclosures, and all the cases in this presentation are my personal cases. So whatever I have learned over years from my own complications as well as from the complications of others, I have tried to make it into a learning point. So I'll try to share in the next 15 minutes. So complications, we all know, are great levelers and they make you humble. So it is nothing wrong in having complication, but there is this saying, famous saying, and the only real mistake is the one from which we learn nothing. So complication give us to introspect and to learn for life. So that is what complications is, and the most common complication in thoracic spine surgery, the dreaded one, are the neurological deficit, most commonly either due to screw malpositions or because of iatrogenic spinal cord injury. Then there can be CSF flake, and if you're biomechanically not strong, then there can be implant failure. These are the common ones. And the various common thoracic pathology in which this can happen is all we know: degenerative deformity, tumors. And I will try to tell you by a case-based example how you could avoid it. So whenever any case, I usually follow these basics of do no harm and what are the patient complaint and whether are these complaint relevant are explained by the lesion. What are we dealing with, either a benign or a malignant pathology? Because doing a radical surgery in a terminally ill patient is not a good choice. So that's important. And whether the lesion is completely accessible if you are dealing with tumors, what are the risks involved? And for thoracic spine particularly, at any cost, do not handle and retract the thoracic cord. That is the basic thing which I usually follow. Coming to a very common procedure, thoracic pedicle screw placement, but quite a lot complication can happen in that. And many a times visualization is very poor, especially in upper dorsal spine when you cannot see much with your C-arm. And not everyone is lucky to have a navigation. So it all depends on the anatomical landmarks. And always, whenever you're putting thoracic pedicle screw or any pedicle screw, you have to study and imagine the 3D anatomy of the vertebral column, how in each particular patient, where the landmarks will be and where the pedicle will be in which angulation. If you have that picture clearly in your mind, probably then you will be safe. And the entry points, by and large, this is the Roy Camille technique, and it holds true. The center of the transverse process and the center of the facet joint, the junction of it, and by some variation in upper, middle, and lower thoracic spine, this is the standard entry point. The angulation varies. In the upper thoracic, the transverse angulation, the mediolateral, is quite high, up to 15 to 25 degree. As you go to the T10 to T12, it's almost straight. So no mediolateral angulation, and the sagittal angulation is around 10 to 15 degree in the thoracic spine from cranial to caudal angulation. And what I usually follow in putting this pedicle screw is osteotomize the inferior part of the inferior facet, and that exposes your entry point and helps in accommodating the screw head also. And then the standard all to break the posterior cortex. Then the gear shift probing, this is important. Many people favor a straight probe, but this gear shift probe in which you are lateral initially will protect the thecal sac. And once you have crossed the pedicle around 15 to 20 mm, then you make it medially and it will be in the right position. The most important is the tactile feel in pedicle screw, and avoid any jerk, any force, and support your leading hand. Don't be under pressure. At times in kids, they are very tiny, and any undue pressure you can slip your probe and injure vital structures. The most important thing is the feel, and you have to confirm with pedicle sound, palpate, repalpate, palpate all the cortices, and then if needed, do the reaming and then put the screw. You should also be aware of the salvage technique, just in case the pedicles are sclerotic or there is a breakout. Then there is this technique called as the outside in-out-in technique, in which you enter from the proximal part of the TP, go outside the pedicle and enter the body directly. It can accommodate a longer screw, and it requires a more medial angulation. So this is one salvage which you can do. And if you are fortunate enough to have navigation, then use navigation, especially in thoracic spine. It helps. It helps a lot, and can biomechanically you can put screw in good trajectory. So to key learning point in pedicle screws is to imagine the 3D anatomy, and tactile feel is the most important. If you need to exert force in a cancellous bone, probably you are at the wrong place. So ideally in cancellous bone, your gear shift probe should ideally move without much resistance. If it is requiring force, then means you are ideally actually hitting the cortical bone and you are in the wrong direction. And navigation, if it's there, you can use it. So coming to some case-based example, a degenerative spine, a dorsal myelopathy, power 4+/5, D8, D9 disc, a black disc. On CT scan, it's calcified also, and the patient is 4+/5, so almost normal. And the patient has come to you with myelopathy. And this is the CT scan showing a dead central calcified dorsal disc. What to do? Whether to do a posterior approach or a posterolateral approach. So posterior approach, as you can see, goes in this direction, which will require some amount of handling of the cord, which is not advisable in a compromised cord. So in comparison, a posterolateral approach will go from towards the ribs and to the ventral aspect without touching the cord. So the postural approach is favorable here. There is a transthoracic approach which can also be done, but more and more people are doing posterolateral now because of the training. Many are not trained. Even I am not trained in the anterior approaches, the third transthoracic. So posterolateral works well. So the anticipated difficulties are risk of neurological deterioration and risk of CSF leak because of the calcified dura. So I decided for a posterolateral approach, and we should all know this approach, a costotransversectomy or lateral extracavitary approach. So costotransversectomy removes around 4 to 5 centimeter of rib. However, the LECA or the lateral extracavitary makes it more lateral, up to 8 centimeter of rib, so that you can reach more ventral and more to the opposite side. So this case is actually very well suited for a lateral extracavitary approach. You can give a long midline incision or a VVS or a T-shape incision, and I prefer the T-shape incision since you are destabilizing a lot of facet, TP, and even the ventral disc. So I decided to fix it one level above and below. And then this rectus spinae can be divided or looped. It's quite bulky, so it was divided, and the rib gets exposed. This is the measurement, up to 8 centimeter of rib being exposed. And we did a rib resection up to 7 to 8 centimeter. And this you can see that my drill is actually below the cord and ventral to the cord. So this is possible, and this is the post-op picture. We could safely remove the calcified disc, and the patient had a very good outcome at 3 years follow-up now. So the key learning point again is the posterolateral approach allows for circumferential neural decompression under direct visualization with extrapleural dissection, and single stage ventral and dorsal column support can be achieved using the same incision. So we should learn this and it's useful. Another case, a very common OLF, ossified ligamentum flavum. You can see multi-level, multi-segmental, and ossified everywhere. Ventral disc is also ossified, and the dorsal OLF also. So dural ossification is very common in these cases, and we should carefully see it on the CT scan, the comma sign and the tram track sign. As you can see, a comma sign here and it shows anticipated difficulty in removing this ossification. And if it's a tram track sign, then it means that the dura is also ossified. Again, in these cases, it's important to use the drill properly. Drill should be used like a paintbrush. We should not do focal drilling at one point. And especially the diamond drill can be used near the dura. So no focal drilling and only the side-to-side movement. Again, OLF also is very tricky, and you have to do initially a cutting burr and then the diamond burr at the end. Use the thinnest upcut to remove the last portion because the cord is quite compromised. And then you can elevate this. You can isolate this island if it is ossified and very much stuck to the dura. But with careful microsurgical technique, this all can be very well decompressed. So in OLF, your drilling technique is quite important. So the key learning point in OLF is, again, carefully study all imaging, including CT, anticipate the problem, proper use of drill, and use floating technique if the dura is ossified. Then comes the complex spinal deformity, the kyphosis and scoliosis, which I do. And these are quite challenging cases because the patient have come mostly for cosmetic deformity, especially scoliosis. But kyphosis, they can have are very much compromised. So to manage this deformity, we should have knowledge about spinal osteotomies, and there are various and higher grades of spinal osteotomy, starting from the Smith-Peterson osteotomy, in which bilateral inferior facets are removed. And actually, it's a posterior column shortening osteotomy. So you can correct 10 degrees of kyphosis with each level of Smith-Peterson osteotomy. And it's quite useful in scoliosis as well as kyphosis. The higher version is a pedicle subtraction osteotomy, in which you can do almost a 30-degree correction. And the more advanced is a VCR, in which you actually remove the entire vertebral column at that level for rigid fixed deformities, hemivertebra, butterfly vertebra. And this can all get corrected after that. The spine basically gets detached above and below, and then you can align it in the way you want. So like this. So one of the case, a 14-year-old adolescent idiopathic scoliosis, simple Lenke-1 curve, 51 degree. This is my planning. And as you can see, this is the osteotomy done at the periapical region, 2 or 3 levels periapical. And once that is done, the spine is released, then you can correct this deformity. And this is what the pre-op and the post-op. So it's quite a straight spine after your osteotomy and alignment. Another case, a very advanced case, a double curve, thoracic as well as lumbar. And we could do the same by doing a periapical 3 or 4 levels osteotomy. And this can all get aligned very well. A kyphosis, again, this is due to L2 incarcerated hemivertebra and a 46-degree lumbar kyphosis, which should be ideally lordotic along with scoliosis. And here, this is the additional hemivertebra. And we did a VCR here, removed that hemivertebra, and then corrected the deformity over the mesh cage. And this is the post-op, in which there is a good correction. The COP angle has decreased from 36 to 5 degree for that kyphosis. The coronal COP is also quite improved. So all these osteotomies are pretty important, and we should have a sound knowledge of this thing. It can help you not only even if you're not doing deformity, in tuberculosis of the spine, and even in degenerative scoliosis, if you're managing, it can help to correct all this deformity. Then the spinal cord tumors, which all of us do, the intramedullary spinal cord tumor, the complication avoidance depends on the careful identification of the midline, and it is usually based on the dorsal root entry zone, and we have to be extremely careful where are we doing the myelotomy, and use the diamond knife or a number 11 or 15 surgical blade Do not unnecessarily coagulate and just do a very fine dissection with micro dissector and a traumatic fine tip suction. And we all know that you have to be extremely careful to the ventral aspect where there will be corticospinal tract, and to identify the true tumor and cord interface, use neuromonitoring. This is mandatory in these cases. So to learning point in these surgeries are these are technically challenging surgeries, and reasonable balance should be there between long-term tumor control and functional preservation, and a proper myelotomy, tumor interface, and careful use of bipolar helps. And intraoperative neuromonitoring is actually a standard of care in these cases. So coming to the safety, whether intraoperative neuromonitoring is actually needed or not, and there are various modalities: SSEP, MEP, D waves, trigger EMG, and pedicle screw testing. The MEPs and D waves are important and should be done. Ideally, multimodality should be done, including the SSCP. But MEP and D wave are pretty important, and how it helps. This is the case of cervicodorsal intermedullary ependymoma with a power of 4/5. Upper limb and lower limbs are actually normal, and this is the baseline
Dr.
MEP.
Sachin, next 1 minute, just summarize.
I'll do that. So this is the D wave baseline, and when are we doing resection, there is change in the MEPs. So the MEP is going down, but the D wave is intact. So if we didn't have D wave, then we would have to stop. But since we have D wave and which is intact, so we continued with resection. And this is the MEP stack view. The MEP remain compromised, but the D wave is intact. And immediate post-op, there is just 1 grade deterioration in power, which is expected in an intramedullary tumor. However, the patient improved to the same level as pre-op at the time of discharge. So this D wave monitoring and the multimodal intraoperative neuromonitoring is pretty important. So it's very promising technology, and it increases the safety of surgery. All this deformity, intramedullary tumor should always have neuromonitoring. It's not a luxury, it's a necessity, and may soon become a standard of care. And sometimes doing less is actually also enough. This is a case of vertebral hemangioma with a severe cord compression, patient coming with myelopathy. And in this case, rather than doing an entire vertebral column resection with anterior and posterior fixation, we just did a short segment fixation with an absolute alcohol injection. The patient improved dramatically and is on follow-up now for last 1.5 years. And all the epidural compression, everything has gone, and it works well. So we do not need big surgeries every time. So depending on the pathology, we can do. So to conclude, you learn more from failure than success. So failure builds character, and despite having the complication, better is possible. So for the next surgery, so complication are the great teacher. Thank you so much.
Thanks, Sachin. I'd like to invite our next speaker, Dr. Sudhir Dubey, consultant neurosurgeon at Medanta Hospital, New Delhi. So his talk is on complications in minimally invasive lumbar spine surgery, prevention and management. Please go ahead, Sudhir.
So I will be talking about complications. I have a lot of them. And before going through that, I have studied some literature for that. The incidence in prospective studies is around 20%, and in retrospective studies, it is around 16%. The most commonest being hematoma, infection, CSF fluid leakage, mechanical complications, neurological, systemic, and even surgery-related deaths. Oncology, degenerative are two spectrum of surgeries, and infection and trauma also come in between. So depending on what kind of complications they have, you will have different category. Hematomas will be more in oncology as expected. Infection, because already the spine is compromised, it has more neurological complication. CSF leak becomes more in degenerative because people become more complacent. And oncology has more deaths compared to other things, and mechanical failures happen because infections can make the upper and lower bodies difficult to address. This is a paper from one of the centers which once they started using advanced technology like navigation and monitoring, they decrease the complications. So problems which you face and you can prevent complication is you should choose your indications well. The problem can also be the wrong patient, wrong level, wrong site, for which the checklist, pre-op checklist is very important. And it is very important in thoracic spine. Extent of bony work, because you may sometimes become tired. It's a 2 level, 3 level. If it's a intramedullary tumor, if you're not exposed all, you will have more problems later on. So bony work should have been done before. Extent of dural opening also becomes important. It's complication in general. I will take you my missed TLIF complications. Technology can sometimes, if the your tool shifts, like if you have ported a probe there and the fixed probe moves somewhere, then you are going to cause complications. Monitoring helps, and monitoring should always be used. Hemostasis should always be there. CSF leak should always be prevented, and they can be prevented more in minimally invasive compared to open surgeries. And neurology is the most important thing. You want a walking, talking patients in the end of the surgery. Surgical site infections are less talked about, but you deal them with them in the outpatient when the patient come, and it takes away a lot of working days and a lot of hospital visits for them to treat this surgical site infection. So if you take the steps of surgery, various steps can make you go through different problem. If you don't pad the patient enough, these are not done properly, you will have a problem. Incision, if you have gone on the sides or there, then you will have more problems when the retractors come in. Like in this case, if you are doing a TLIF and you are not parallel to the end plates, you are going to have problem in doing this TLIF, putting the cage. You will cause bony disruption, even the cage won't go properly. So preventing complication comes at the level of incision. For a TLIF approach, we have to know that we have to unroof the foramen. That is, we have to take out the facet joint above and below, and we have to go into a safe area, which is between the exiting nerve root and the superior end plate of the vertebral body below. And this is where you remove this and you unroof this. So this gives you a right space where you don't touch the nerves, we don't cause distraction, and your neurological injuries are less. You have to go anteriorly, you have to release anterior to get a good release so that you can get a lordosis. Then, whenever you are doing a minimally invasive stuff, it is very easy to go from one end to another. So you may have a disease here, but your angulation, and you may start operating once you have put the dilators and you're not cross-checked. You can always go above and below. Also, the problem is of lumbarization and sacralization. So either you have to have this view X-rays before, and you should have thought and contemplated about it, or you have to do the marking intraoperative with the MRI, with the vitamin E capsule. You can do that marking and then go ahead with the surgery. You can always have a wrong trajectory. So this in this TLIF, I went more laterally. So I was making dilatation laterally, and you can imagine going and pressuring slightly more, I can cause more damage on the sides. Dural tear is a common complication which can happen, and that especially happens when you are taking the last bites and you are not careful. This is an inferior bite which I took, and there was a dural tear. And I knew that I've torn something, I can see the roots coming out. So at that time, once you have seen this and you have caused this, you should first put a Surgicel, don't touch the roots anymore. You have to do adequate decompression first, and then you finish the procedure. So decompression only will help you once you have taken out the disc fragments, when you have taken out other things, and you have done a amount of decompression which is adequate for you. Then you will be able to do the procedures. The root will become lax and they will go inside. This is the only video I have, so I'll just fast forward it. So once it becomes lax, and you also move the ligament, it's a small tubular ports with which you do TLIFs these days. So once you have decompressed it, you can go ahead and do the procedure there. Now, what happens? There are also cage complications. The cages can go anteriorly. This is when you are going inside, you have not checked the C-arm at the proper level. You go on hitting, and suddenly the cage there is a resistance, and then suddenly it gives way. So it can go anteriorly. This has to be taken out going from the front. And if you do the procedure by just leaving it like that, then you have not achieved the surgical principle of what you wanted, that you wanted to do a reduction, you wanted to increase the foraminal height and decompression at this area. This you won't do if you do this. Sometimes in patients over a period of time, when your cage is not snugly fit, and this bony formation doesn't occur, the cage also slips out. This is one patient of mine which presented after 1 year with sudden excruciating pain. Mostly it was because the cage had not fused. I might not have done enough of disc work and not put enough of bones inside, so that after 1 year it came out. Sometimes when we are putting a cage, and as I told you, the port is not properly aligned or bone has edema, Schwall's nodules are there, then the cage can go inside like this. Now, if you do a procedure like this, what will happen is there is a destruction of the bone which happens on the top, and this is a bad thing to happen, especially if there's a listhetic component and it is not reduced. So when you do this, you will not get the adequate amount of result which you want to get the optimum results. Bradycardia is another option which happens to patients whenever we put the cage inside. This we have been noticing for 20 for past 20 years, and this happens because we do neuromonitoring. The patient is slightly light, and in around 20 to 30% patients, we notice this. Uh, we try to change a lot of things, but it happens each time when we put a cage inside and we are trying to distract the vertebral body. So it's due to dural stretch, which is believed to be, but it happens in some patients. But it is responsive. As soon as you stop hammering it, it stops there, it reverses back. Very rarely have given atropine for this kind of a condition. Guide wire complications are very common, especially when you are a beginner. So we have a department where we have fellows with us. We have to give them work to do, but sometimes these kind of pictures can come, and sometimes you get away, but it can be when you look at these images, you are yourself scared that what happened to the patient. Patient somehow with guide wire, they don't do so badly, but has happened in a lot of our patients. Like it would have happened in 1 or 2% of the patients that the guide wire get lost. Then there are screw complications. Sometimes you don't measure the screw in length. Sometimes you tap them more. So you can have this much screw which may go ahead, and there may be the iota which may be lying in front. So you have to be very careful and measure it whenever you are putting the screws, and you have to make sure on the AP and lateral views that you have done the proper job before breaking all the things. Sometimes you do like this is a patient where patient had a cancer, and we did a kind of a decompressive procedure with a tube, not exactly a TLIF, but what happened, we put a cement inside the body because the bone was weaker, and when we put that, the cement migrated, and we had to decompress that. You can see the cement migration happened at that time, and we had to decompress with a port. This is a reference frame in one of the patient who had weaker bones, not the T-score was around minus 2.4. We had a thing which went inside the bone very easily. But fortunately, it was a intra-poam was there. So, there is some muscle hematoma, but nothing breached inside and nothing major happened. Then there are miserable complications which we have also faced, like a central retinal artery occlusion, Guillain-Barré syndrome, demyelination in brainstem, and Dietl's crisis. This is one patient who, after 10th day, came with drowsiness and low GCS, and you can see a demyelination in the brainstem, which is here. And the patient was treated with steroids. She improved and became normal. This I have seen around 4 cases of mine, not only TLIF, central artery retinal occlusion, 3 were in the cervical spine. So post-op patient had some edema here, and when he woke up, he didn't had this vision, and one field was totally gone. So we attributed it to central retinal artery occlusion. We try to pad adequately, try to reduce the fusions have more central retinal artery occlusion than otherwise. Beatles crisis, one patient who had a bladder bowel involvement. We put a catheter, there was 1 liter of urine which came out. And then the patient went into severe electrolyte imbalances. We found out the release of hydronephrosis sometimes causes this Beatles crisis. And it took around 2 to 3 days of managing them that they became all right. Hemoperitoneum, one of the patients, the wire went ahead, we caused a hemoperitoneum in that patient. Patient woke with post-op anterior thigh pain, and there was some swelling there. So we did an ultrasound. We found some hematoma there. We did a CT. We found a hematoma. That was okay because it was not increasing. The patient didn't hypotense, but after 2 days developed hemothorax. It went through there, and then we finally had to put a chest drain, and the patient recovered from there. Neurological worsening is also very common. It's more common in thoracic discs. And some patients, if you don't do a proper job or if you have a blood clot, sometimes they can be, like in this case, we had a deterioration of patient. This was the pre-op, and in the post-op scan, everything got obliterated. We had to decompress. Patient subsequently improved. In this one patient, we put the cage, and when we tried to rotate it, it went on the opposite side. That caused a radicular pain on the opposite side and some amount of foot weakness. So we had to revise it. We had to go from the other side and revise it. We also had cage complications, like sometimes the cage subsides, sometimes it migrates anteriorly. So more when you are putting the cage, you have to be more careful where exactly you are putting it. And if you don't put it properly after post-op scans, after some time, you will find that the cage is lying loose and it is not doing its proper job. Dural tear I have already covered. Bleeding is also one complication. It happens at times, and that normally is controlled with packing. If you are patient enough, that's not a big problem. It's no major, this thing is there. I will share one L1 fracture where I caused a ventral dural tear. So I will take you through that video. This is, I'm doing a corpectomy. We do a minimally invasive. We don't need to open. We can take out all these things, but we still cause complications. So this is the dural part which is there. I will take you through. This is the final bit where I'm taking out the anterior part of the bone. And you see I'm going inside. I've gone through the dura. There's some leakage you will see here. So I was pushing there, and I think this, I thought it was epidural. I was pushing this fragment down, and there's a dura white which is seen there. But I think when I was pushing it down gradually, it was something gave way and the root started prolapsing. So I want to show this that you can still recover from this kind of a problem. This was a final fragment where I caused some amount of. So this
Sudhir,
is a huge.
you have 1 more minute.
Yeah, it will finish by that time. Don't worry.
Thank you.
I just wanted to show that if somebody has a tear, they can treat it like that. That's fine. No other interest. So there's a CSF leak here. So what I did was, because the nerve root was seen, I put a smart Durafoam, which I've slid into the dural defect directly. And then I had to pad this adequately with the grafts and everything. So there's no redundant nerve root syndrome. And because this is thoracic spine, there's no spinal cord which gets adherent to that. So that is what I did. And similarly, I had some problems in OLIFs also, but I think for brevity of time, I will stop my presentation. In this, I had a tumor was there and I had caused some ureter injury. So this tumor was just ventral. If I take you through the patient's, I think that scan has gone. So tumor was just lying anterior when I was doing it, taking it out. It might have been adherent, so there was some ureter injury. So I caused the urologist there. So they were not able to suture it. So because we are used to this minimally invasive and we have been suturing it for a long time, I only sutured this ureter. We had to watch with ultrasound in the post-operative phase. We had to watch with the ultrasound. Patient didn't develop hydronephrosis. There was no leak after that. and everything went on well. So this was one of the case, some bone fragments similarly like that. But I think I will finish this because of brevity of time. One thing which in TLIF we have to be very careful if you have osteophytes. So these are two-level things, and at one level the osteophyte was not removed properly, and when we didn't remove the osteophyte, you can still see a lot of osteophytes. Lower one it was removed, and when it was not removed, patient developed weakness after third day, and we had to remove it again. So osteophytes, be very careful if they are into canal, you have to remove this. So the complication in spine surgery are very high, that are to the region of 20%. I have caused enough of them. They can lead to increase in cost and hospital stay. And there are very traumatic events in patient journey. Even a wound problem is a problem for the patient. They are preventable at most of the times if we think. And as I told you, the 10 commandments are more important. I teach my fellows that they should follow that. And in case of complication, always think the worst first. See, I have in my experience, when I cause complication, I try to be more conservative. And the other, if the complication is caused by others, I will be more expansive to tell what you need to be done. So when the complication is yours, you need to be more expansive in telling that this all is required, have a more radical approach. And for other complication, be less expansive and tell in smaller lines. So that is what it should be. So thank you for your attention. This is what I wanted to share. Thank you.
Thank you, Sudhir. It was an excellent collection of very good cases. Thank you very much. So we have 15 minutes for discussion. So what we'll do is we'll first take comments and let the panelists share their experience. Then we'll take on the questions to the speakers. We'll start off with Patka sir. Your comments, please.
No. In the line of seniority, I think you must first ask Dr. Pragnesh Bhatt.
Okay, sir. Okay, I'll take it. Pragnesh sir.
Thank you very much for inviting me and giving me this opportunity. I have learned a lot more than I have ever taught in the last 1 hour. And I would only quote Einstein to say that clever people solve the problem, but genius avoids those. Thank you.
Patka sir.
Yeah, I feel these were very interesting presentations by all three of them, and they were so technically focused. I feel that big surgeons are surgeons who have had big complications and did not get sued. Then they become big surgeons. I don't know whether every neurosurgeon must read the book Skeleton in the Cupboard by Rodney Marsh. All neurosurgeons, they have their complications which stashed up in their cupboards, who come and visit them when they're alone and sitting in the balcony in the night. And then they remember that these were the patients who got worsened. I would summarize that the biggest complication and the commonest complication is the wrong indication. Next thing is the wrong technique. Third is the residual disease. I always urge to the new generation of spine. There's such a big, exponential kind of explosion of spine surgeons all over in the country and abroad, that everybody must focus on, most important, proper training. Workshops don't make spine surgeons. The most important is apprenticeship. And I feel that most of the complications that I see is because of poor training. So first is the wrong indication. There is a very beautiful saying that in spine surgery, only the first operation was not indicated. All others were indicated. Subsequent operations to solve the problem were indicated. But why did that first problem occur? The commonest reason is that it was a wrong selection of the patient. The second thing, of course, is wrong training. The third thing is the kind of infection and dural range. And then things like wrong level, adjacent level degeneration. And now this splurge, actually, we are neurosurgeons, and I find that luckily we are focused on the problem. But when I see I'm working in a place where there are a lot of orthopedic surgeons, I see so much of excessive use of instrumentation that proximal junctional kyphosis and proximal segment degeneration are very real and existing problems which need to be touched upon. That proximal junction, when we do spine instrumentation and even deformity correction, we should learn properly what we are supposed to do. and how many levels we are supposed to fix. Just knowing how to do the pedicle screw is not important. We must know when to do the pedicle screw and to what extent we must do the fixations. Because there is a lot of, I think business funds medicine, and medicine stimulates business. Of course, we need business on our side. Without business, we cannot progress. But I find many times that the indications of spinal surgery are modified because of the business of spinal surgery. The number of the population has not increased, but the indications for spinal surgery has increased so exponentially over the years, and the number of patients being offered spinal surgery is so high. Nobody is ready to accept that we are all programmed to become old, kyphos, and get fused. This business of putting cages in every particular spine that you see, I think, is a surgical overkill. I, of course, know that I am at the other end of the spectrum, and there are many young spine surgeons who might say that "Sau chuhe kaake abhi billi haj ko chali ya boka haj ko chala." But this is what I look at it, and I feel that less is always better. So let's see what happens over the period of years. But I feel I was very happy to see when Dr. Dubey said that the incidence of spine surgery is 20%. Tell me how many of us tell our patients that the overall incidence of complications is 20%. Most of us will tell the patient that 2 or 3% and 98% become all right. The truth is the 20% go bad. But then, of course, if we talk like that, then nobody's going to get operated by us. But we have to be conscientious, like I said, regarding the indication, regarding our own training. There's nobody who can monitor. You have to monitor yourself what you can do and what you cannot do. Just because somebody else can do it, that does not mean that you can do it. You have to train properly. Thank you very much.
Yeah, thank you, sir. Vernon?
Yeah, thank you, Abhay, for this kind invitation, and thank you, MCNS, for including us as a panelist. And I've heard congrats to all the speakers today who have touched on avoiding complications and also trying to show some management of complications. So I work in a government institute, so we have to handle a lot of redo cases. And when there are redo cases, the chances of complications are high. So I will start topic-wise, where Dr. Katikar showed some good cases, some complicated cases and challenging cases, and where he has shown the different types. So I think the most important thing is to foresee the complication first and be ready mentally, because sometimes you cannot avoid it. And you don't have to do very, very complicated things to do this. You have to do a simple recce, which we do in our OR. First thing is study the scan, study the X-ray, and study the MRI properly, and look at the area which you're going to target, which you are supposed to operate last, in my opinion. As a trainee surgeon, one should look at that area the last, and then make your decision to operate. Second thing is, we have come from ages now, and I've learned that in cervical spine anterior surgery, you have to do what is required. You don't need to do too much. Like Katikar was saying, that he drills the whole body for removing a disc which is just going behind the body. You need not do that. You can just do a posterior partial corpectomy. Just like when you drill the osteophyte, you're almost doing the same thing, and you can get the disc out. That is number one. And also, continuous retraction in the neck is not good. We have stopped using continuous retraction, because today we get elderly patients who also have a lot of carotid arteriomatous disease. And when you retract the carotid artery for a long time, you can end up with strokes, you can end up with neurological complications which are unrelated. And many times this can happen. And as far as thoracic spine goes, in my experience, I have moved to around 80%, we do it anteriorly through the thorax. If the patient is not fit, only then we go posteriorly. Otherwise, you can get the maximum decompression and lesser complications, as thought of before, that it is very morbid and it is very, today with a mini thoracotomy, you can put instrumentation, you can do 3-level fixation, and it can be done safely. If you have a good access surgeon, it is not difficult. So that is also one thing. And of course, neuro monitoring is a good thing to have, but sometimes it can get you into a little bit of problems, especially if the D waves go off too early. So you are left in a sticky situation where you have to come out and ask the relatives, see, we are seeing this problem. And should we continue, or we might stop and then go on another time. So there are problems with neuromonitoring also. And in the third talk, I think Dr. Surish showed so many different things. But what I feel is when there is a complication of CSF leak in a minimally invasive technique, it is very difficult to repair. You sometimes just end up doing packing and hoping that everything would go okay. But if it was a slightly bigger incision, you would go and repair and probably sleep well that same night. But when it is minimally invasive, you are crossing your fingers. And we have seen cases where anterior dural leaks are the most difficult and most high pressure leaks to manage. So you don't come out that easily without a CSF leak if there is an anterior dural tear. So this is what is there from my experience. And the most important thing is counseling the patient and their relatives, because they expect miracles. They have come walking to you and they expect that patient to go back walking. So whenever we do surgery, especially OPLLs or large osteophytes, hard discs, you have to be wary and you have to be counseling the patient's relatives completely, telling them that you might not get 100% relief. So it is very, very important, because most of the litigation cases, which we have seen through our experience, as we are a government hospital, they are mostly spine. They are mostly spine cases which have landed up with complications or deficits. And that's the place where things are difficult to justify. So this is my advice to the younger generation. Choose your cases properly, see all the investigations. And today also 3D CT scan and 3D models, especially in scoliosis, kyphosis, it can help you to plan the surgery. Even in scoliosis, if you have a 3D model, you can plan your screw trajectory. So these are the things which one can use the investigations to the max to get the better results and avoid complications. Thank you.
Thanks, Varnan. Chandan, you want to moderate the question and answer session?
Yeah, so I'll have a question for each of the participants. So for first question, I'll ask Dr. Katikar sir. Katikar sir, I think I agree with Varnan sir when he says that for when you have posterior osteophytes, doing a corpectomy, I think is a bit more aggressive because we are able to get away with using with drilling the osteophyte posteriorly with a diamond burr, and we are able to do it pretty safely. So that is my only thing. Is there any specific reason why you would do a corpectomy over just a simple discectomy when you feel that a fragment has gone retrovertebral?
Yes, I won't do it for every case. What I have seen is that the disc is herniating beyond more than half of the body. When you go on pulling, on a few occasions, I felt part of it was left behind. Over a period of time, it may get aspirated, it may get absorbed. And about the osteophytes, simple osteophytes, we do remove with ACDF. But there are huge osteophytes which are kissing each other. In spite of all the drilling, you are not able to reach the the posterior end of the osteophyte. And in these cases, instead of struggling, and when you reach the dura, you are thinking now how to remove this. I think when I speak with others and I show them my cases, they say, no, but I feel we are getting in our area, which are much more huge, much more huge osteophytes than others are showing the images. So I have the images in which you can see on the X-ray huge osteophytes, which cannot be removed.
I would like to come here inside. Hello.
Yes,
sir.
Sure.
Yes, sir.
I feel I am inclined towards Dr. Katikar. The decision of whether to do corpectomy or not depends upon how much the disease is extended retrovertebrally. I've seen so many times people trying to remove the osteophyte from within the disc space and leaving behind a significant component above and below. If the osteophyte is extended above or below the disc space, then the best thing would be to do at least half of the corpectomy of the vertebra above and below. Because the main purpose, see, you have to believe in your philosophy. Either you believe in decompression or you believe in just fixation. If you believe in decompression, then you must see the normal dura, which is non-compressed, above the pathology, and you must see the normal dura below the pathology. If the disease is extended both above and below the disc space, then it would be prudent to spend time till you reach the normal dura. Just trying to see the dura at the side of the pathology and leaving some osteophyte above. Unfortunately, most places don't have intraoperative imaging like a CT scan or say an MRI. Then it would be better and safer to go and see the dura, normal dura above and normal dura below. And that would involve probably, therefore the CT scan becomes very, very important. To what extent is the bony compression? Soft tissue compression, I agree, you can remove without doing corpectomy. But if you have got a bony compression, which is extended in retrovertebrally above and below, I would be more inclined towards doing what Dr. Katikar is saying. And there's no harm. Ultimately, the aim of the operation decompression, see that you have got it done,
So
I don't know.
the other way of I think the other way of asking is like, do you take the decision for corpectomy before the surgery, or is it sometimes also an intraoperative decision?
Very
I would say
rarely,
that
very rarely drop. Almost 99% I had already planned it.
Okay.
Very rarely.
Okay. Sir, Patkar sir?
Yeah, I agree with what he's saying. The whole planning is on the preoperative CT scan. The corpectomy is decided only if there is no soft tissue, if there is a bony compression. With a soft tissue compression, then you would not require a corpectomy.
No need.
Okay. Thank you. Thank you, sir.
Chandan, there are some
sir-
questions in the chat box you want to ask.
Yeah, so I think first question was what was probably to Dr.
Sudhir,
Sudhir's chief. Chief, what was the reason for demyelination in the case that you showed following the spine surgery? Was it like a stress induced or a post infective?
No, it
Hyponatremia.
was nothing. It was nothing. No, there was no hyponatremia. There was nothing. It was a neurological illness, and they diagnosed with the LP, and the patient became all right with steroids, methylprednisolone.
Chief, one philosophical question, because some of those intraop Siam shoots you showed with with the wires going in anteriorly, I know it must be so scary for you to see that, and you might be feeling like really losing your temper. So I know you are a training institute. You have trained a lot of people. So what do you do if you have a complication like this? You see that the wire has breached, and your resident or fellow has done that. So for the next case onwards, do you do the screw
Yeah,
fixation
you have to
yourself, or
again, no, you have to, once you have to have, we have a teaching routine. Like we will ask
right?
always them when they are placing the guide wire and everything. We'll go through that steps once again, all of the steps once again. But sometimes what happens, this usually happens two, 3 times. Two, 3 problems are the most common. One is when the frame moves, the reference frame moves. That is when it happens. The second time it happens is when you have put the wire and you are pulling it out, the outer sheath through it, then it happens. These are the two most common things when it happens. And third, when you are tapping, then it happens. It happens more often if we have a trained scrub nurses who have been told to monitor this guide wires when they are putting it. So we have some checks and balances, but it sometimes happens, and we then do a ultrasound. We follow up the patient. Fortunately, we didn't have to open any abdomen for that, but it has happened. So I showed my cases for that reason.
Okay.
So
Another
always check
problem.
it, cross check it. Always think your wire is going to go ahead. That is the only philosophy that will make it less.
Dr. Dubey, especially when you're doing transforaminal surgery, when you pass the guide wire through the needle and then pass the dilator over the needle, over the guide wire, and when you're tapping the dilator into the disc space towards the foramen, that is the commonest time when the guide wire goes inside. I mean, sometimes it can go across the vertebra into the retroperitoneal space.
So these were
I don't.
most guide wires where when we're putting the pedicle screws. So transforaminal approach I will be doing, so that has rarely happened, but these are because a lot of young people train with us, so it happens with them. So that's why I shared.
I used to have this problem when I used to do transforaminal surgery, that I used to first pass the needle, then the guide wire, and then put a dilator over it. And by the time I pushed the dilator, I used to find that the guide wire has gone across the vertebra. So I made it a point to mark after I push the dilator where I am, and I should see that the mark doesn't go inside. With
Or you can
the
take a fluoroscopy also and make it.
correct. You can do it under continuous fluoroscopy also, but that involves radiation, of course. But I appreciate what you have shown, and that was a very, very challenging problem. That you can get shocked when you see the guide wires in the retroperitoneum, and they can give an ectopic heartbeat, but most of the time nothing happens.
No, that is not the message. Message is that you should treat every patient that
Yeah,
the
I agree
catastrophe is
with you.
just sitting there. Yeah.
There's no question. There's no question. It can be catastrophic. That guide wire is capable of causing
We would have
treacherous
lost so much of our patience and happiness for these small things.
Yeah. No question about that.
Sachin, Chandan, can I ask you a question?
Sure.
Sachin, how do you prevent reperfusion? This is one of the commonest questions asked by many of these students. Whenever there is severe compression, either in the cervical or a thoracic, this thing, how do you prevent reperfusion injury? What are the measures do you take?
Actually, there is no way, especially in tight cervical spine. What we usually follow is to use a very thin upcut if you have to use. No big instrument, because the foot plate of upcut is also quite big. So if you are putting a 2 or 3 mm upcut, then it can further compromise the cord. So any compromised canal anywhere, especially cervical and dorsal, I prefer use the thinnest upcut if you wish to. At times in tight canal, especially in cervical OPLL, and with the effective canal diameter is quite less, many a times it may not be preventable, but people have suggested obviously laminoplasty over laminectomy, so that and obviously taking care of the surgical tips of not handling the cord at all. And obviously anticipation and prognosticating the patient before. At times, despite a very good surgery, patient can end up with a white cord.
The question is, Sachin, is the blood pressure monitoring during surgery plus
Obviously,
steroids,
all
is
things
there all these? Are they important?
Mean arterial pressure and everything is definitely important and is usually taken care of. But despite that, it has happened many a times. So I think others can comment, senior people, whether they have found some tips which can prevent it. Surgically, I don't think I have found anything which could have prevented that.
Yeah, Sachin, I must congratulate you on one thing that you stressed. A very important sentence in your presentation was use the drill like a paintbrush. That was very important. And I think all juniors who are listening should focus on this sentence which said that use the drill as a paintbrush. Don't drill only in one place. You first decide from where to where the pathology extends, and use that beginning from the end of the pathology on either sides. Use the drill as a paintbrush. In fact, the first description of an ossified posterior ligamentum phlemosus was published by me in Surgical Neurology in 1994. Surgical Neurology. In 1994, I had published a paper that there is this pathology called ossified calcified ligamentum flavum. Anyway, that is not important. But this drilling using it as a brush is extremely important. Only then, when the whole thing thins out, then you can crack it and lift it up at some point, rather than trying to put the Kerrison punch between the ligamentum flavum and the dura and cause damage to. I do not, just like, I don't know whether many of you know, there is a paper by Dr. Wadia and Dr. Gajendra Singh and Dr. Wadia long ago in CV Junction, where they described hematomyelia following foramen magnum decompression in severely compressed cervicomedullary junction in fixed atlantoaxial dislocation. Those days I was a registrar with Dr. Vengsarkar. Now it malice to nobody and not trying to give trouble to trying to belittle anybody. Dr. Vengsarkar had commented at that time to me that Patkar, this complication is not because of, there's nothing like, reperfusion and decup. It's not a prostate gland where you remove the prostate and there's bleeding in the kidneys because there's a long-standing compression and urinary obstruction. This is because of a thick footplate of the Kerrison punch. So this was the comment of Dr. Vengsarkar when that paper got published in Neurology India, that following foramen magnum decompression, there is hematomyelia at the cervicomedullary junction in a very tight, compressed cervicomedullary junction by a ventral odontoid because of fixed head. Because those days there was nothing, Dr. Goyal had yet to publish his papers, and they had described only foramen magnum decompressions. So I feel what you said is very important. People have to learn the master. I don't know those courses where they used to teach people to use a micro drill to drill out the egg shell of egg till the membrane is there. I think that is very, very important. Medtronic used to do that course. I don't know whether they still do that course, where you use an egg, not a boiled egg. You use a regular egg with the micro drill. You drill out the shell till you see the membrane and you see the inside soft kind of yolk and the white of the egg, which is floating inside. That is the best way to train yourself in trying to do bony work on spines where there is severe compression.
Sir, may I just intervene? What Dr.
Yes,
Patkar sir said about the paper, I had heard because I am trained from that institute. Nothing
Yes.
wrong, but we learn by the mistakes.
Yes,
So
I
it
agree.
was said that the bone wax was applied by the thumb.
I'm not believing it. They were great giants. They were great giants.
They were great giants, and they have taught their students that
Yes,
the
yes.
main issue was applying the bone wax with the thumb, and that used to injure the cord more than the footprint of the Kerrison. Yeah. So then they started
those
applying.
days, there was no Kerrison punch available less than 3 millimeters.
3 millimeters. Yes.
Pragnesh sir, yes, you raised your hand. Go ahead, sir.
Thank you very much. So coming back to the inadvertent pushing of the guide wire, I think when somebody is trying to pull something out, inadvertently our mind tries to push something. And especially in osteoporotic spine, I have seen wire going more than what we wanted it to be. That's one thing I would like to contribute. And of course, I have enjoyed all the presentations, some of the pearls of wisdom, not only from all the speakers, but from the faculty and the panelists and moderators. Thank you.
There's a question from Dr. Londe. Sir, do you want to unmute yourself and ask this question exactly? What do you want to ask? Unmute yourself, sir. Yeah.
Am I audible, please?
Yes.
Yeah.
Go ahead, sir.
Okay, sorry. Just to clear my experiences at times, whenever there is severe compression of the spinal cord, be it in the cervical spine or be it in the dorsal spine, especially in the dorsal spine, anterior or posterior, and I see changes of ischemic changes in the spinal cord on the MRI scan, I prefer to use a drill and thin out the lamina or the bone which is compressing, and then thereafter, as was said earlier, when it is extremely thin, you crack the eggshell. But despite this, I have seen some neuroworsening post-surgery. So I was just trying to find out from the esteemed panelists and the speakers whether there is any other way in which this particular problem can be avoided.
Yeah. My friend from Ireland, he has described a technique that in severely compressed cords, break the pedicles, don't drill the lamina. He goes lateral to the spine and breaks the pedicles and lifts the whole posterior. Dr. Pragnesh, but who is the famous neurosurgeon from Beaumont Hospital? What is his name? I forget his name. It's a kind of Indian name.
Kiran Bolger.
Kiran Bolger. He has described a technique of breaking the pedicles and lifting the lamina with the broken pedicles backward. Are you aware of that paper of his?
Well, I have not read that paper. Yes,
No, I'm asking, Pragnesh Bhatt is very close to him. Aberdeen is on the same platform as Dublin. And Kiran Bolger used to talk about, he had done a lot of experimental work. He used to be against drilling the lamina and the spinous portion. He used to go lateral and break the pedicles on both the sides. Now that is easier. He used to first drill the transverse processes and then break the pedicles and cut the pedicles. Now, maybe that is a other end of the spectrum, that you don't do anything, just cut the pedicles and lift the whole thing en masse posteriorly.
Is that a
So-
common practice which is seen by many other neurosurgeons as of now? I'm just trying to understand.
Just like, in cervical OPLL, way long back, I used to talk about vertebral body advancement, and now that vertebral body advancement is a very, very kind of, very advocated technique in Korea for OPLL, where they say you don't sit and drill the vertebral bodies. Go and advance the vertebral body. Well, that's just like laminoplasty from behind. So advance the vertebral body along with the OPL anteriorly. I did not pursue my work because I did not get those many patients. But I had presented in APCSS that technique with the instrumentation manufactured by Geom. So what you're saying is correct, that in spite of doing very careful drilling, you can still get neurodeficient.
So in that particular case, as was discussed earlier, whether it is the compression or whether it is the reperfusion which is the cause of the neurodeficit.
I'm not very keen on accepting this theory of reperfusion. Anything that is compressed is compressed. If the question is whether you can decompress it without causing further damage due to your procedure of decompression.
I think what I feel, Patkar, is that
Yeah.
decompression has to be gradual.
Correct.
You got to take your time in decompression.
Yeah.
So you take more time to decompress level by level instead of doing it very quickly. So what we have realized is when you do the drilling and you are doing it gradually, so you're allowing the cord to expand. And also there should not be hypotension when you are doing
That
this.
is it. Most important.
Yeah, so you have to have normotension. So that is very, very important. And use a diamond drill more than a cutting burr. Diamond drill would be better. So what I use is a bigger burr. I don't use a small burr. I use a bigger burr, which should be a 5 or 6 mm burr. And do a gradual decompression level by level. Instead of going from one side, like a laminotomy, you go level by level. Do it, start from down, say C7, then go to C6 both sides, then go to C5 both sides, and do a gradual sort of a laminoplasty first. And another important thing is when you're taking off the lamina from a thick ligament. So you have to be in a proper plane. You should not go in the plane below the ligament initially. That's why. So these are the things which one has to do from both sides.
What is your opinion about my statement? Decompression is a negative operation. Decompression is a negative operation. The problem is instability, not compression.
Yeah, but we are talking about avoiding complications here.
Yes. So now the question, we are operating to bring improvement in the patient. Decompression is a negative operation.
I'm answering the question asked.
I'm asking a new question.
One more important thing which I have realized is don't decompress in a valley, make it a gradual plateau.
Yes,
So if there is a severe
that is what we're-
compression, make it a gradual plateau. Don't make a deep valley, because if you go into a deep valley, like corpectomies will be better than ACDF at times for osteophytes, because you are not going into a valley and you are making a plateau because you're going from top to bottom and doing a good job.
That-
So that is very important. Don't go into a valley. If you go into a valley, you try to go attack just that thing and you're not gone above and below, then you are more likely to land up into neurological deficits.
That is exactly what Sachin said, that paintbrush.
No, have a wide area. Don't go into one spot, even if you are paintbrushing. Make a wide area of decompression, then you take it out. Means always
Yes.
have a more wider area than possible.
Yes, I agree with
Sachin,
that.
go ahead. Sachin,
Yeah.
go ahead. Yeah.
Regarding this, what Dr. Vernon saying, I agree with that in cervical spine. When you're doing a gradual thinning, and that it should work till the ligamentum flavum and gradually at each level, and then remove the ligament with the thinnest 1 mm or 1.5 mm upcut. That at times I feel those patients didn't develop deficit, but if you do a on block sort of pulling the entire lamina, with basically shearing of the lamina without properly releasing the flavum, that is one dangerous thing not to do. In OLF, obviously, what Dr. Nitin practices, everyone does the same thing. Again, thinning with initially a cutting burr and then a diamond burr maybe. And if we feel that it's not thin enough and it's causing some sort of traction on the cord, then it may be a wise thing to isolate it and keep it there rather than trying to remove. Many a times what happens is the dura is ossified and there is some sort of tenting on the cord because of that ossified mass. And if we try to remove it, that is the cause of deterioration. It may be better to isolate it all around and leave it rather than trying to be absolutely clean scan, because there is no tensile, there is no pressure, because it's isolated from all sides, the cord will shift back or the OLF will shift back. That is better or easier to than to do a pedicle to pedicle work or an anterior sliding osteotomy for OPLL. They are theoretically very good to be seen, but very difficult to do, especially 3 and 4 level OPLL anterior sliding. It's actually not very easy procedure to do. This is my personal opinion.
Dr.
Yes,
Katikar, you want to answer Dr. Kiawat's question there? How will you do a fusion after doing half corpectomy?
Sir, actually, whenever I do a half corpectomy, when we remove the disc, we have the cage which can fit into that. But half a corpectomy, you may have to drill some more bone, because the smallest size is 20 millimeters. So whenever we do a partial corpectomy, the largest ACDF cage is about 12 millimeters. So we reach the 20 millimeters and we are able to put the cage inside. But on occasions where it is in between, then at that time I use the iliac crest bone and put a knee plate on that.
Your mother.
So one question was that whenever we use these expandable cages and we put in the graft and then we expand it, so we never have bone on bone contact.
Yeah.
Once we do that, and I
Yes.
think that is a problem with expandable cage anywhere, be it cervical or thoracic or anywhere, and you have to supplement it around it, which is not usually you don't have that much space. Maybe in thoracic spine or lumbar it is possible, but cervical definitely you don't have too much space to supplement bone around your this thing. So I think that is so I think the one message that you should give is that try to use the correct size cage, and then the expansion should be only to fine tune. I've seen people trying to expand the cage double the size by using a very small cage. I think that is not a way to use an expandable cage. It goes against the principles of fusion.
No, let me explain. The expandable cage is to have the appropriate height of the cage. This from 20 millimeters, it can go to 25 millimeters. So instead of having 20 millimeter cage, 21 millimeter cage, every millimeter cage, you are having the cage. You know what is the size you need. You expand to that level, you fill the graft from end to end. So there is end-to-end bone contact.
Correct.
You don't have to put in and then expand and say that there are bone fragments lying loose. You know what size you need. The advantage of
Correct.
this is that you can use any flexibility from 20 to 25 or the bigger from 25 to 35. So you don't have to have that much inventory in your hand. Then another thing, after expanding, when we have put the bone, there is a bone to bone contact. The third thing is that I always try to go as laterally as possible until I see the origin of the dura, the origin of the root. So it gives me enough space to pack the bone around. And we have done scans of more than 20 people where we have seen the end to end. There is a central stud graft at the center, and all around the bone has formed anteriorly almost as a vertebral block, and the posterior part is totally devoid of the bone. So I have the scans which I can share with you. These scans show that there is an excellent fusion all around through the center and even through the holes of the cage. The bone has grown out and it has gone and touched the vertebral body on the lateral side, the lateral part of the vertebral body which was cut.
I think the success, I think the success of the fusion, once you're distracted, is not just because of bone-to-bone contact, but also how much gardening you have done of the end plates. If you have not done good gardening of the end plates, that bone is going to float and get reabsorbed. But you have done gardening, then there's osteogenic material which is going to grow from the end plates. If you don't focus on the gardening on either side of the cage, then I think whatever you do, whatever distractor you use, whether you use a mesh cage, whether you use a peak cage, or whether you use a distractable cage, all that is useless. The gardening is important of the end plates.
Correct. So the expandable is mainly to show it can be expanded, not
Correct.
that you have to put it and then expand.
Correct. Okay, any more questions and comments?
Just a comment about what Dr. Kiawat asked, how to do maybe a partial corpectomy. Does anyone perform a partial corpectomy and put a cage between the end plate above and the cancerous bone below? Does someone practice that? Because we have been conventionally trained that the graft should be between the end plates. But I have seen some senior people, not neurosurgeon, but orthopedic spine surgeon, doing this partial corpectomy thing, and they say that they have excellent result, and there is no need to remove the entire body. If you have to just remove maybe a osteophyte, which is upper 1/3 of the body, you remove the upper 1/3, put a cage or a graft and plate it. So
Don't
any
put a cage.
experience or
Don't put a cage. If you do this, you have to always use a bone graft.
Yeah, I agree with you, sir. But is it advisable? Because again, even if bone graft, it can countersink in the cancerous bone.
I think a little amount of kyphosis doesn't make a big difference in your outcome. There is no point in trying to struggle. See, what is the relationship between kyphosis and neck pain? It is not, there is no kind of case to case, 100% that if there is a little kyphosis, the patient is going to have axial pain. It is more of a theoretical issue rather than a true one, If you see a long-term kind of fusions using when we used to use bone grafts in the pre-era of this cages, almost everybody had up to 15% kyphosis, but nobody had neck pain. Patients were happy. If you ask the senior surgeons who did operate like Dr. Ramani, Dr. Turel, they will tell you that they have done a lot of fusions when cages were not there. And in fact, the fusion rates were better when they used bone graft, autograft, rather than cages. So little kyphosis, we should not be struggling to get a kind of completely lordotic spine. And all grafts that we put are actually sequestrums. They don't have any blood supply. They are going to die and they're going to settle a little bit. You are going to have 10 to 15% loss in the height of the bone graft. Now, how much kyphosis will happen not only depends on the graft, but also how much laterally you have decompressed. The more lateral decompression you have done, the more kyphosis you have.
Can I intervene?
Yeah.
Can I intervene?
Yes,
Dr. Kiawat here.
Yes, sir.
See, when you were supporting Dr. Katikar's opinion that there should be corpectomy and you should remove the disc. If you do corpectomy, it will be half corpectomy above, half corpectomy below. How will you fuse this?
By putting a bone graft.
No, may I answer, sir?
Yeah. So
Sir,
how will you fix the bone graft?
Sir, I will not do this when there is only disc. I will do this only when there are huge hard osteophytes or huge OPLL. Whereas the Dubey sir told that instead of making a deep valley, make a trough. So this is possible only if you go away from the cooperation. At the site of the operation, you go on going deeper, 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 and you don't know at what time suddenly the dura will open. So whenever I am doing it, I do one level corpectomy above. So one disc below, one disc above, and the vertebra in between. So here it gives me a virgin dura from where I can go and perform my operation with very ease as compared to struggling with a narrow canal. And about fusion with a bone graft, what Patkar sir and Borkar sir said is correct, that if you put a cage inside, it will sink. But the cage I am using, so it has it does not have any spikes above and below, and it has the attached wings by which it will get fixed to the upper and lower vertebra. So in this case, I would not claim that I have done in many patients, but in about 5 to 6 patients where I had to do half corpectomy, and I thought I should stop here, and where the height was more than 20 millimeters, and I was able to put the cage, they have fused excellently with that because the plate above and below is fixing, the central part cannot sink in. And as it does not have a spike, it has a rounded margin, the cage which I use. So it never allows a lot of sinking, and the screws and the plates holding up the screws attached to the wings above and below, they put it in place, and by the end of 3 months, you are able to see excellent fusion throughout, even in these patients.
Whenever I have done like this, I have got some subsidence and loss of slight amount of lordosis in those patients, but it was asymptomatic. So I've done in many cases like that. It doesn't cause problem.
Okay, so it's 20 minutes past, and can we stop now?
Yeah.
Is that okay? Yeah. Okay. On behalf of MCNS, let me thank all the speakers and the panelists for taking their time off and being with us here today. Thank you very much. Good night.
Thank you so much. Good night.
Good night.
Good night to all the speakers and good night to everybody else. Good night to